Hey everyone, Dr. Sonya here with Dr. Nick. Welcome to another episode of Health Ignited. So today we're going to be talking about an interesting and very intriguing topic, and one that's at the forefront, I think, of a lot of our patients. And unfortunately for us as naturopathic physicians, we can't necessarily prescribe this, but we can point you in the right direction and get you education and get you the research and the resources that you need to make a decision for yourself.
Mm-hmm.
Yeah.
Yeah, absolutely. I mean, so we're going to be talking a lot about CBD, THC, medical marijuana. You can call it whatever you like. Some of us have had recreational experiences with it. Others are using it for medical purposes. So we're going to dive into everything you need to know about this. And, we're really excited about the guest that we've got on today because she is an expert.
That's right. So we have Dr. Sherry Yafai MD. She is a Cannabis and Emergency Medicine physician at Providence St Medical Center since 2009. Dr. Yafai started her medical career at UCSD Medical School, graduating in 2005, and UCSD Emergency Medicine Residency in 2009. In 2017, after recreational marijuana laws had passed in California, Dr. Yafai opened her private cannabis clinic, the ReLeaf Institute, where she sees patients referred by physicians for cannabis education and treatment. Roughly 75% of her patients are over the age of 50 and prefer to use non-smokable cannabis products. So thank you, Dr. Sherry, for joining us today and teaching us and sharing your wisdom with our listeners.
Thank you both so much for having me today. This is a very exciting time.
Mm-hmm.
We're crossing borders.
Oh, totally. Yeah. Well, it's funny. It's, you never know how you're going to meet someone too. And, we didn't know who you were before we had a mutual patient introduce us. And it's just, it's a real statement and a blessing for technology that we're able to, cross borders and cross cultures and cross, our different practices and to learn from one another in such a manner. So yeah, again, thank you for taking time from your busy schedule to be here.
Thank you. Yeah, I think cannabis is really going to be leading the way in terms of this kind of revolution in how we share information in the medical world and how research is done in the medical world. So, we do a lot of research-based, very focused on one chemical and one chemical alone, and we go do 200 patient randomized clinical trials. Whereas in cannabis, we're seeing the population bringing forward the data and pushing forward the medical indications. I mean, we've never quite had a medicine that has done that well in a couple of 100 decades, a century or so. So we haven't been in this place, and more than that, we haven't been in a place where we can communicate like this, right? This new digital revolution.
Mm-hmm. Totally. Well, I couldn't help but be pulled. You did a documentary called Cannabis and Your Doctor, and I encourage anyone who's interested, curious to look into it because there's so much amazing information there. But one of the things at the beginning of the documentary that you did was so good, and it was you were talking about a dialogue between other doctors and their patients, and a recommendation going out, oh, you should smoke some pot. And I think I'm quoting that properly. You've got pain, why don't you smoke some pot? And the patient's kind of like, okay, where do I go now? Well, look it up on Google and you may find some answers. Walk us through that journey a little bit, because that must have been just eye-opening for you to think that, here's a recommendation coming from a doctor. You would expect it to be a little bit more substance to it and more resource. So, and maybe that might lead you into a conversation of how you got started on this field.
Right. So that's exactly right, Dr. Nick. I came at this about 5 years ago with a close family member who got diagnosed with cancer. And after going to the oncologist, their response, this was just when cannabis was under the guise of medically legal in California and still not legal in Canada. And the suggestion was, oh, if you're feeling a little bit nauseated, I hear you can smoke some pot. And when we came to ask more questions, they just kind of shrugged their shoulders and said, I don't know, Google it. And if you're anywhere near the remotely in medicine, Google can be your arch enemy sometimes, especially when being in the emergency department for all this time, when patients come and say, oh, I Googled it, I know I have, appendiceal cancer. And you kind of roll your eyes sometimes and say, well, gosh, like we're going to take it one step at a time. You might just have heartburn. Like it can be that simple. So to find a position where you're in, where the physician is now telling you to just Google it and figure it out on your own, seemed very contrary to everything we do in medicine and everything we try and kind of encourage patients not to do. And so we were now stuck in a place where, you want to smoke something that you've previously only thought about as real, like hard drugs, and like I'm about to go out and do cocaine and heroin. And, that perception was really at the forefront of my mind, at least. And I know at the forefront of a lot of other people's minds. And so to have our doctor and our oncologist suggesting that seemed really odd. So inevitably we did Google it, and we went online and figured out where to go to. And it looked like a fly by the night kind of doctor who maybe had lost their license at some point in their career and was wearing a Hawaiian t-shirt with, like shorts on, and didn't look at us and didn't really pay attention to what we were talking about, and just asked us to circle a part of the body that was bothering us. And that was the end of it. It was maybe a total of 8 minutes. And wow. It didn't seem like, as a physician, it didn't seem like the right way to be assessing what was going on. And
that sounds like an early high school experience for me when we, that's what you expect to see, right?
Right, exactly. Yeah. And then we left that facility it should be called the clinic, but we left that office space and went to a dispensary, which at the time looked like a pager store that had been, all the pagers were taken out of the shelves and like pot was put in, like there was a bunch of different type of weed that was put in on the shelving. And we just kind of like asked, we've got a friend here who has breast cancer. What should we do? And they said, well, this one gets me really high. And that was the response from the bud tender behind the counter. And it was just kind of, no, that's not what I'm looking for here. I need something else. And getting that not so, what's the word I'm looking for here? Not really clinical or a real medical pathway, and not really feeling like your needs are being met or heard. By somebody who just smokes to kind of get stoned all day. And again, this is not meant to be across the board. And this was 5 years ago. We've really come a long way in cannabis in general. So we don't get that routinely anymore. But that was what prompted all of this, and saying, hey, we need to do better for our patients. And we've got a lot more options nowadays. And why don't we take those options more seriously? And part of what we see in the whole kind of field of cannabis is that 80% of this is really recreational use. And there's probably about 10 to 20% of it that's truly medical use. And what we're seeing is, before it used to all kind of hide under medical, and now it's kind of all hiding under recreational. So either way you swing this, we're not getting a real sense of what's going on. And we really need to do better for everyone. And we need to start outlining better what everybody's needs are. We don't need to hide under one umbrella or the other anymore. So
and I feel like I was just going to say, I feel like when you're in that position too, like your friend that was, had this diagnosis of breast cancer, or if there's somebody else that's dealing with chronic pain or severe anxiety where their quality of life has diminished so much, they're in such a vulnerable position. So if they're not feeling safe and in understanding how to use something that maybe they did have that perception of, like, if I go down this route, will I become addicted? And well, like all these other misconceptions that we may have because of the lack of understanding of how cannabis works and how it works with our biology and just everything about it. So I think it'd be great today for you to create some clarity around that too, between CBD and THC, and just when you would use what. I think so people start to understand, because I do feel like there's a lot of confusion around that. And I actually have a patient who moved from Mexico and was dealing with multiple seizures. Like her son, after the age of like 4 months, was just having seizures all the time, and was put on some cannabis, and he was seizure free for over a year, if not 2 years. And then, but when they moved to Canada, that shifted because of the dosing and just how the product was made, and then the seizures came back. So I think just creating some clarity around that for us would be amazing, of like, what is CBD, what is THC, and like, what do we want to look for?
Right. So you bring up an excellent point. So when we go from kind of recreational use, I mean, even in recreational use to true medical use, we need to start talking about things with clarity, right? What are the dosages? What are the chemicals that we're using? What are the, how frequently do we want to be dosing this? So all of these really important strategies. So if you think about the term cannabis, so people are like, where did this new lingo come from? It's not new, it's old lingo. And it's the very scientific term for the umbrella kind of concept of marijuana. Marijuana is actually a very historically racist word that comes from actually Mexico. So it's the term Mexicans used to describe marijuana or cannabis. And it was in the 1920s, the reason it got really prolific was because it was a term that we started using in order to put Hispanics and Blacks very specifically in jail or to deport them. And it became, if they're using marijuana, it's the devil's seed, it's the devil's plant. We need to get them away. And we need to put them in prison because they're going to be they're going to rape women, they're going to be troublemakers, they're going to kill people. And that was where all of this hype came from. Whereas before, in the early 1900s and 1800s, we were using cannabis tincture in our oils for cough suppressants, for nighttime sleep tinctures. So Eli Lilly, a very famous pharmaceutical company, was using this very much. And so we had to create this new kind of hype around something old. And the way to do that is to rename it. So now we're going back to kind of our roots. And what we're seeing is the term cannabis being used because we're going back to the scientific essence of this. And we're trying to avoid any, slang terminology. When you talk about alcohol, we talk about alcohol. I don't talk about drinking a fifth of hooch, right? That's not what I talk about. And then neither do we use the term hooch in our medical scientific papers. But what we still see used is the term marijuana in our scientific papers. So even at the core of it, we're still not used to separating out what's science from what's lay terminology just yet. Now, that being said, if you think about cannabis as the umbrella term, that's kind of the big word that describes the plant. Then you start getting into the details of the actual chemicals. So THC is probably the most well-known chemical in the plant, and it's because we have been using it for centuries. THC is the part of the plant that is euphoric or makes you feel good. We're no longer using the term psychoactive because that means that it's active in your brain. But we know that CBD is active in your brain as well, right? That's how it controls seizures. So CBD is psychoactive, but it's not euphoric. So it doesn't make you happy or feel good. So that's the two major chemicals that we're talking about. So THC and CBD. CBD is the non-euphoric part of the plant that was previously most well known for being in the hemp subcategory or subtype of cannabis. And hemp classically was really being, grown for its bark, for its strength. We're using it to make paper and book bags and things of that nature. And about, I think 10, 20 years ago, we found that the CBD chemical in it could be of benefit for seizures very specifically. About 10 years ago, Charlotte Figge, a young girl in Colorado, really made it famous, so to speak. And one of the ways she made it famous was being on the 60-minute episode with Sanjay Gupta.
I remember watching that.
Yeah.
That was one of the major scientific kind of reviews that changed my perception on this plant. Because Dr. Sanjay Gupta did an amazing job of taking a look and really seeing what this is helping and how this could be helping. And he really made Charlotte Figge a new model. Unfortunately, she passed during COVID due to COVID, which was a really upsetting time for a lot of us. Okay, so getting back to THC, CBD. So those two are referred to as the major cannabinoids in the plants, and the ones that we are seeing produced at the largest amounts. They're the ones that are getting a lot of research and studies. But what we're starting to see pop out of the woodworks is actually the minor cannabinoids, or what I like to refer to as the alphabet soup of cannabis. And it's the CBDA, THCA, CBG, CBN, CBV. So you've got a lot of different other letters being thrown out there, and it can get really confusing for people. And so those are the ones, though, that we're starting to see some benefit in terms of anxiety and anti-anxiety medications, inflammatory bowel disease, and nighttime sleep and insomnia. And we're going to start seeing more and more data and literature pop up about these things, especially because none of them are euphoric, none of them make you high. And because they can access them through the hemp plant, one of the things that we can see is that it makes it easier to do scientific studies and research. So that's going to be interesting as the next 5 to 10 years kind of come forward. In terms of names and words, sometimes people ask me about all the different names and words that get thrown about here. And so far we've talked about cannabis, hemp, marijuana, so weed, pot, I think Mary Jane. I mean, you could come up with probably like 50 different names off the top of your head. All of those really are referring to THC-based products. And mostly you're talking about things that are being smoked. Then you get into the other words like dab, weed, and dab, shatter, dab, wax, and shatter. Dab, wax, and shatter. So, right, I see Dr. Sonya, you guys can't see this, but Dr. Sonya is making a face like, oh, that's interesting. There's even more to this.
I know, I had no idea.
So it gets even more complex. And dab, wax, and shatter are basically, you know, us children of the 70s and 80s, we used to think of hash or hash oil. And what that refers to in all of those terms are much more higher concentration versions of THC, really specifically. They have a place in medicine, but for most people, I would say stay away from dab, wax, and shatter. For all newcomers and novice users, for sure, you should stay away from it. And for people who generally don't have much expertise in this, I almost always say it's for expert professional use only. And then I'm going to get into one last kind of caveat with all of this is vaping versus smoking. And this is a lot of like people throw these words around now, and it's really, it gets a little bit complicated. So smoking is anytime you burn or you light a fire, right? And you're smoking either a cigarette or you're smoking a joint, which is like a rolled up part of the plant. You know, you roll up the plant itself in paper. And when you do that in general, in medicine, we think of smoking as not the preferred route of giving people medicine. It works in general very quickly, which is why people like it. But if you're going to burn plant or burn paper material, that burned product can also be considered carcinogenic or can be cancer inducing. We haven't seen any studies that show that cannabis in and of itself, either smoked as a joint or otherwise, causes lung cancer or any other types of cancer. But if you were just going to err on the side of safety and what you would recommend to people, I would err on the side of, you know, you probably don't want to smoke a joint, so to speak. But the flip side is you can vape flower. And that's kind of the preferred novice. If you're going to try something you've never tried before and you want to try this recreationally or medically for the first time without any other sort of medical advice, that's probably the way I would suggest you do it. To vape flower. So it's two parts. So the vape part of it is it's a heating element. So you're heating it up. You know, you might think of a bong. You might think of a vape, like a vaporizer that's almost like a small little, almost like like the new cigarette versions. But it's heat, right? Like exactly. Yeah. All of these different kind of ways that you can vape things. So it's the heating element behind it. Okay. Now the flower aspect of it is probably the best way you can do anything, because it's very hard to overdo flower in and of itself. And it's very hard to have any sort of overdoing it, overdosing, which is a non-lethal overdose, but it makes you feel bad when you do too much by accident. And this is just generally the best way you can do it without kind of having any other medical advice on it.
Mm-hmm. That's awesome. I definitely am not ready for the shatter and the dab, and those sound really intense.
I've already learned so much.
Yeah. Well, it's funny because I mean, maybe not everybody, but some of us have had experience, you know, smoking a joint and trying things out when we were younger and sometimes when we were older. And to be honest, like it's always been an aversion for me because I feel like essentially I feel stupid, and I feel like I've probably had too much when I've had it. And I imagine that there's some hesitancy for people when they feel like they've had a bad reaction. So I think it's so important for people to understand that there are different doses, different strengths, different ways to use it. There's the euphoric, psychoactive, as you broke it down so eloquently, there's different ways to use this. So let's talk a little bit more about that, actually, because I think it's important for people to understand they can take it in tincture, they could do it topically. Can you talk about some of the different ways that people could use this?
Sure. So that's exactly right. So number one, about 20% of the population doesn't do well with THC. It just doesn't feel good to them. It makes them either feel a little paranoid, it makes them anxious, but about 80% of the population, likes the way it makes them feel. Okay. And I want to say that kind of really clearly, because people have this expectation that they're going to be, totally stoned in 5 minutes, and no matter what they use, and they won't be able to think clearly, and they'll be a different person. It's very mild in general. Like, if you think about this as a medication, it's a very mild medication in general. Now, when you dose up on it, or when you increase your dosage, or the number of hits you take, or inhalations, or what have you, that effect is going to kind of continue to build upon each other, right? So it's a really dose-based medication. That's kind of part one. Part two is that reaction. So about 20% don't do well with it or don't feel great with it. About 80% like it, right? Which is generally why you have the mass population enjoys this. For that 20% who doesn't enjoy it, you can see a flip reaction with CBD. So just because you don't like THC doesn't mean that you won't do well with CBD. In fact, I see that people who don't do well with THC do very well with CBD. And it kind of works like a yin and a yang model. So the two really complement one another. And vice versa, people who do really well with THC oftentimes say CBD doesn't do anything for them. So it really depends. And I wouldn't throw the baby out with the bathwater. If one thing doesn't work well for you, there is some flexibility and room for you to try out other things. Now, talking about tinctures and dosages and whatnot. So in general, CBD and THC have very different dosing strategies. And what I tell people is if you were going to take Tylenol, you wouldn't take the same dose of Tylenol or paracetamol, I think you guys use, or acetaminophen. You wouldn't take the same dose of that as you would, for example, oxycodone, right? So you take 325 to 650 milligrams plus of acetaminophen, whereas you take 5 milligrams of oxycodone. So the milligram dosing doesn't equate with these two different medications. And the same thing is for CBD and THC. For CBD, you're seeing higher dosages because that's what's more standard in it. You're talking about anywhere from 10 to 50 milligram dosing, depending on your size, your weight, your gender. Whereas with THC, you can use as much as 0.5 milligrams in an oil tincture, upwards to 10, 5 to 10 is really more standard. But you can use higher dosages of each depending on what we're discussing. So for example, my patients with mild neuropathic pain, I had one of my very first patients had severe neuropathic pain of the face, and they can see, Dr. Sonya and Dr. Nick can see me pointing to my face here, but and was really bothering him, tried to take Percocet, tried to take muscle relaxants, went to 3 different specialists, an internist, a family practice, dermatologist, pain management specialist. None of them could help him out with pain, and tried about 3 to 6 different prescriptive pain medications as well. Nothing helped. But we started him on a very small dose of THC in an oil tincture version. And small refers to something like anywhere from 0.25 to about 1 milligram of THC. And started there and gradually built up and was able to not just do well with pain, but virtually have no pain by the end of the time that we were adjusting this dose for him. And that became an easy remedy without getting him high, without making his memory feel fatigued. Something like Dr. Nick, you mentioned, without making you feel kind of funny. It really has to do with that dosing regimen. And this was a guy who was roughly 60 something at the time. So, right, and age is going to affect how this makes you feel. So this is the other aspect of why, you go see a physician versus dosing medications on your own. because I would never
Look
say,
up for the
hey,
Hawaiian shirts.
right, exactly, right. Look out for the Hawaiian shirt. But like, hey, you can dose, whatever you want of Norco, Percocet, Oxy, hydromorphone, Dilaudid. I mean, take your pick of whatever it is. I would never say that to you as a physician. But on the other hand, we're expecting patients to walk into a cannabis dispensary on their own and pick out any variety of dose for their problems. And that's where it gets a little bit tricky, right? A child with pediatric epilepsy and seizures is going to get dosed very differently from a neuropathic pain or post-herpetic neuralgia pain of a man in his 60s, versus a postpartum mom with depression who's no longer breastfeeding and needs to sleep through the night because she can't get through the night without sleeping. All of these scenarios are so different. And yet when we talk about cannabis and cannabinoids, we don't talk about these differences. We don't talk about like THC is not the same for any of those three individuals. And yet we're using THC for all three of those individuals. We're using CBD for all three of those individuals. And how can we do that better? So really focusing on what the diagnosis is, right? Just like when somebody comes into your offices, I imagine you ask what your diagnosis is or where your pain is before we start talking about the treatment plan. So we need to start we've been working backwards in cannabis for a lot of decades, but we need to start kind of rewiring people to start talking about like, well, what's the problem we're dealing with here? And how can we do this better?
That's awesome.
Yeah, I'm so glad you're bringing that up. And I want to kind of talk about that 80% that you had mentioned earlier, how, 20% may get that reaction where they're just maybe not wanting to do it again. So they need some education on like different ways that they can use it. And then there's the 80% that do really well. And especially with something like pain, because as you probably know, with all the patients that you work with, when you're in pain, your quality of life has really diminished, and it affects not only your own relationship with yourself, but your relationship with your family and work and all these things. So have you ever seen somebody do well with treatment and kind of get dependent on the treatment? And I know cannabis's nature is different than some other addictive substances and even medication, especially for pain. So can you maybe shed some light on how that it is different and what you do to help support people not become dependent? Because I mean, it's the same thing with, we talk about food relationship, we talk about even codependency in relationships with our partners or whatever it is. Anytime we're dependent on something to take our pain away, even though it may not be an addictive substance, we are, as humans, we can become addicted to it because it becomes habitual, it becomes part of our life. And have you ever had to coach somebody to let that go, or how do you navigate a situation like that?
That's an excellent description and an excellent way of presenting it. Thank you so much for that. So with any medication that makes you feel different, and any medication in general, quite frankly, we do see some addiction and some dependence. So there's two kind of separate words that we're throwing out there exactly because of what you described, right? Addiction is really like, I need it, I want it, I have to have it. And dependence is my body is now dependent on it, whether or not I necessarily want to take it. And so in cannabis in general, so I'm going to separate out the THC and CBD again. So THC, we see about anywhere from 9 to 15% addiction rate. And primarily those studies have revolved classically around teenagers and 20-year-olds who smoke pot. Okay, so teenagers and 20-year-olds who are smoking THC. That's really where we're studying those levels of addiction across the board, right? Whether it's with this or nicotine or alcohol or opiates, etc. Then you get a separate category for CBD. So CBD, I will tell you right now, has 0% addiction rate. It's been studied. There's no addiction that we've seen till now. If you tell me that the addiction rate in 30 years from now is going to be 1 to 2%, I'll still take it as relatively inconsequential. Okay, and the reason is because it doesn't make you euphoric, correct? So that's the big difference. So we're going to put CBD aside during this conversation, and we're going to focus in on THC. The addiction rate we do see, again, is in our younger population, number one. Number two, that addiction rate, just to put it in comparison and in a bigger lens here, alcohol, nicotine goes 18 to 20 something odd percent. Methamphetamines goes up to about 28%, I believe. So every other thing that we know of as addictive is at least twice, if not 3 times more addictive than this is. Okay, number one. Oh, sorry about that. So number two, the other part of this is that we're seeing is that THC, when given for pain management, for example, and when dosed appropriately, we're not seeing those levels of dependency or addiction that we see with opiates. We can use it, and we're using it fairly successfully in the office and in my clinic. We do it where we are reducing patients' opiate usages and reducing their opiate usage to either, anywhere from 50 to 25% of previous down to 0. And it really depends on the individual. So, for example, I've had 30-year-olds up to 70-year-olds who want to get off of their prescription opiates. And I'm going to specify this down to prescription opiates right now. They have been on their opiates for a number of reasons, from, post-cancer treatment, chronic pancreatitis, chronic neck and back pain. I had a post-polio syndrome patient, and they've been on these opiates for a very long time. And they're trying to get off, or at least lower their dosages, because we know of the consequences you just mentioned. Social consequences, personal disappointment and depression. We're now seeing something called opioid-induced hyperalgesia syndrome, which is a fancy term for saying opiates creating pain that only itself can put out, right? So it creates its own self-fulfilling cycle of pain. And then in that kind of syndrome, we also see a reduction in hormones and testosterone levels, which plays into everything else we just discussed. And then constipation, right? So now people are on 2 or 3 other medications to make them poop in order to kind of feel normal. And even to the point where in the ER, and going back to my roots, one of the things I would see frequently was, I haven't pooped in 2 weeks because I'm on opiates and I can't poop anymore. And that's, if you've ever been constipated for any small number of days, 2 weeks is a long time. And we start seeing other issues kind of result from that. So kind of to refocus, one of the things that we can do, and one of the things I've done very successfully, and it requires a person or a patient who wants to get off of their prescription painkillers, because it's not easy. Even with the use of cannabis, it's not easy. But what we can do is allow them to do it at home, allow them to do it at their own pace, and allow them to decrease as much or as little as they want. And then at the end, they get to decide and choose whether or not they want to remain on cannabinoids or whether they want to come off of them. And quite frankly, they can do either, and they do it very successfully. And the idea at the end of the day is to get patients feeling better. And the problem ends up being is that they're on these huge dosages of opiates and they're still having pain and their lives are still miserable. So what's the point of taking it in the first place? If you're just as miserable as when you started, but now you've taken, 20 painkillers in a day and your life is revolving around them, and filling them, going to pain clinics once a month. You now can't get these pain medications for months at a time. So you have to go get refills every month. I had one patient who said he would hold all of his medications in a backpack. And anytime he left the house, he'd have to wear them around with him for fear someone would break into his house and steal them. Then he wouldn't be able to get a refill of the medications again, and you can sell them on the black market. So he was literally carrying a weight on his back every day that served as a reminder, both physically and emotionally, of how many pain medications he had to take. And it goes into sleep and sleep disorders. So we see very frequently that, if you're taking a painkiller every 6 to 8 hours, which most people are taking much less frequent or more frequently than that, then you start waking up in the middle of the night to take a painkiller. And then your sleep is disrupted. And then again, you see this kind of constant, catch-22. You do one thing to help the other, to help the other, to help the other. And it's a cycle that's very hard to break. So I'm going to give a really amazing example. And this is a patient that I can't wait till he feels comfortable to start speaking out about this. He is a young gentleman, roughly 39 years old, who is on fentanyl sublingual. So we used to call them fentanyl pops, but they're just sublingual tablets of fentanyl. They're about 400 micrograms of fentanyl that he would take either 1 or 2 doses at a time. And he'd gotten to a point where he was taking them every single hour. roughly during the course of the day. So he was taking 400 microgram fentanyl in a day. And Dr. Sonya and Dr. Nick here are shaking their heads in amazement.
Shocked.
Yeah, right, in shock, because you've never met somebody, or I can tell you very clearly, I've never met anybody who's taking that amount of painkillers in a day who hasn't been literally on the end of death, right? In hospice care, about to die in, a couple weeks' time, because that's how much medication he was taking. The equivalent was roughly 1,800 milligrams of morphine equivalent per day. Okay, so to give people a really clear picture of what that translates into. Of course, his bowel movements were off. Of course, he was living his life 1 hour to the next, and just waiting to take that next painkiller. And pushing out a medication dose for him was really 1.5 hours to 2 hours to take his next dose. And he had a change in his life recently, which was having a baby. And I think that really pushed him personally to move forward and say, I need to stop this. And his pain management doctors couldn't do it. He couldn't do it. He had tried doing it on his own with his other docs and was unable to do it. And in the last 3 months, he is now 6 days off of 100% of fentanyl.
Oh my
and
God.
that is crazy. It's just insane to be off that much painkillers in 3 months. And, part of it was his drive and his need to get off of it. But it doesn't stop there, because no matter how bad you want to stop these medications, they will make you vomit. They'll make you have diarrhea. They will make you sweat until you have to change your shirt every hour. They will make you have such bad anxiety that you literally feel like your body's about to explode. And what we can do with cannabis, and for him, he didn't like to smoke. He didn't, quite frankly, like the feel of THC. And so we used a modified program to give him oils and sublingual, a similar sublingual dose of a combined CBD THC medication to get him so that he could just tolerate being off of a portion of these medications at a time. Up until recently, I basically would have never expected somebody to be able to tolerate this on any level whatsoever. And the fact that he's done this without any inpatient treatment, with I think the only other medication he's been using is some promethazine, pharmaceutical prescription wise, because we don't use any other prescription pharmaceuticals, and a little bit of Tylenol to get him through this has been unbelievable. He didn't require any IV fluids, which is, again, one of the mainstays of being able to treat people as an inpatient hospitalized program to get people off of these opiates. And, we're talking about at least a $20,000 to $100,000 hospital stay and withdrawal treatment program that he was able to do in, a tenth of that, if not 100th of that, right? And to be able to do this out of his own home with his social support network at his side, right? And to be able to do that successfully is pretty phenomenal.
Yeah, that part's huge, having that support and that ability to move through the challenges of detoxification. And we at our clinic have helped several people through it too. And it's not an easy process. And especially when they're plucked out of their homes and not in an environment that may feel safe and supportive to them. I think that part's huge for this whole process.
Yeah. Well, and when you were speaking to the opiates, because you brought up, like, we were talking about addiction and dependency, talked about nicotine, alcohol, and some of these other things. I mean, when I hear you go over the story and the stats on opiates, I mean, that's a extreme dependency that people develop. And, not to get kind of like too conspiracy about things, but we know that we're in an opiate crisis, and typically it is first line of defense, especially in the emergency room. So how, if knowing what you know now, if you were able to go back in time and back to when you were before, I guess, using THC and CBD,
The Hawaiian shirt.
Yeah. What would life have looked like knowing what you know now, back in some of those settings? Like, would you would you be pushing for the use of these things versus opiates, or do you still see a role for opiates and then with a very fast track approach down to CBD, THC?
That's a great question. So number one, I encourage everyone on both sides of the spectrum of cannabis, because not everyone is for it. That's fine with me, but to just listen to what people have to say and to not poo-poo it, because that's what I used to do. My very first experience with cannabis in the ER was a 80-something-year-old woman who told me that her pain management treatment for her severe arthritis was a quarter of a chocolate chip cookie. And I didn't understand it. I couldn't understand. It boggled my mind. And it stuck with me because I have a grandmother too, who at the time was also dealing with arthritic pain. And I, of course, wanted to relay back to her something that was working for someone else. And I remember asking her very clearly, you know, so what's a chocolate chip? Like, what kind of chocolate, like, what Hershey's chocolate chip are you using? I don't understand. And being open to the possibilities of other things being helpful. And that's the very first thing I urge everyone to do. The second thing is we've entered a realm where, and this is not conspiracy, actually, you mentioned conspiracy. I want to be very clear. None of this is conspiracy theory. We have great data that backs up everything, okay? So we know that in the 1980s, opiate pharmaceutical companies pushed upon physicians and pharmacists the use of opiates. We know that for a fact. Purdue Pharma has been sued and has lost millions of dollars, but has profited in the billions, okay, to push OxyContin. We know that fentanyl pops, these fentanyl sublingual tablets, have been pushed by pharmaceutical companies, and these pharmaceutical representatives have pushed these upon physicians and the likes and have profited, again, by the billions off of every single individual person who's taken these medications. So there's no conspiracy about that. It's very clear and very proven. To the point where, you know, at one point we were taught in medicine that the fifth vital sign is pain. And I think there was an important factor to that to be addressed, which was that maybe we weren't addressing people's pain at the time, but now we over address it because we have things, scores that called Press-Ganey scores, for example, that reflect upon how we as physicians do. And it's like a Yelp review that patients get to do. And it has some benefit, but it also has a lot of inherent problems in it. And one of the biggest inherent problems is gender, race, etc. That we know that people, you know, are more likely to rate people better for certain genders and races. But the other inherent problem is opiates. And we think that patients give us better recommendations and Yelp scores or Press-Ganey scores if we prescribe them what they want, even though we inherently know that what they want is not good for them. So, you know, taking a step back and again, going back to that pre-Hawaiian shirt day and what I would do, because I still work in the emergency department and I utilize this kind of new information or newer information to our benefit. And I ask patients, you know, I have that, you have to have that deeper level conversation, actually tell them, you know, I can prescribe you Vicodin, but quite frankly, it will do no better or worse for your pain than Motrin and Tylenol extra strength. And let's take that one step further. If I prescribe you Vicodin, I'm happy to do it because I think you'll benefit from it for today and tomorrow. But how about after that, trying to go down a different track? And by the way, you will get constipated with even one dose of Vicodin. So I'm going to prescribe you a stool softener for that so that you don't go through that kind of lesson on your own, because we know these lessons already. How do you feel with that? And you know what? People tend to be very understanding and very appreciative of having that conversation. You don't have to prescribe cannabis. You don't have to recommend cannabis. You just have to give people the option and the right and information to choose what their options are. You know, you can tell them, hey, you know, you twisted your ankle and that's going to be painful. The best thing you can do is stay off your ankle for a couple of days. The next best thing you can do is actually do physical therapy and ice it and elevate it and get it moving again. Because once it gets stiff, then we're going backwards in time in terms of pain management. But you're going to do better if I give you less opiates. It's your choice at the end of the day. And I think giving people that choice actually gives them a lot more happiness in terms of what they get to choose, whether it's opiates or non-opiates. And you know what? Most of the time it's going to be non-opiates if you educate them correctly. And that's all you need to do, is just educate people correctly. And it can be, at the end of the day, it's their option. And if we give them the option, they're more likely to fare better. I listened to a lecture once recently about nutritional content of food, and how there was a great research study that showed that you can write, this meal is 1,000 calories, which is a lot if anybody knows what calories are for a given meal. Or you can put a label on there that shows a picture of a fat person. And you know what? They're going to respond better to that picture of a fat person than they will with the 1,000 calorie label on there. Because to the normal everyday person who doesn't necessarily pay attention to calories, that picture of a fat person is going to make more sense to them than how many calories is in this. And it's the same thing with this. If you tell them that, you may need opiates for a lot longer than you expect, or it might constipate you and it might cause more problems down the line, maybe just use it for a day or two, because it's important for broken bones. I think it has a place and a value there. It's important for a lot of, I always tell people they're one kidney stone away from getting an opiate prescription, because it's horrifically painful, and you want that opiate prescription in those situations. And I want to give you that opiate prescription in that situation. But what I don't want is for you to think that this is candy, or this is easy to come off of, or you can take this consistently and continuously for 2 weeks and come off of it very easily. You can't. And it doesn't matter who you are, or that you've never had opiates before in your life. You just need to be mindful of it.
It's awesome.
Yeah, I love that. I think it's so empowering for the patient too, and for the patient to take that self-responsibility in their own healing. Because I think a lot of times there's this expectation that the doctor will save the day, and that we are not responsible for the choices that we're making also. So I think by educating, you're empowering and putting it back in their hands, but also guiding them at the same time, so that they can make choices that will serve them, not just in that moment, but going forward. So thank you. We need more ER doctors like you, for sure.
Totally. Yeah. I love that you led with education. I mean, I think that that's something that's so easy to do technically, but we don't always make time for it. And I mean, we do, because we're in a setting where that's allowed, but for someone in your position to make an effort to do that, I mean, what if that became more of every ER doctor's dialogue, to really connect and educate the patient? I mean, I'm sure that people are listening are like, how do I find Dr. Sherry? If I get hurt, I want to make sure I go see her. I mean, it's amazing.
Yeah.
We want to share your resources for people to access.
Well, before, I have a question.
Okay.
That I know we have a few minutes here where we want to honor your time, but I have a question for you. So in talking about like dependency and addiction, and just talking about human nature and how the choices that we make can either lead to suffering and keep us stuck in our pain, or they can lead, a life of empowerment and growth and learning. If you had one wish for those that you love, or your patients, of them understanding their body's ability to heal, what would that wish be?
Don't be afraid. I think fear holds us back a lot. I know it held me back for a lot of years about cannabis in general. But, once you let go of that fear, the sky's the limit. You can really change quite a bit, and change for the better, and not be so stuck. Even with these upcoming elections, I think there's a lot of fear, right? There's, 2020 to me has been a year of fear, and I want people to start looking forward and making choices not based on fear, making choices based on hope, or where you want to be, and making choices based off of where you envision things going. And relating it back to cannabis one more time, I think for so long we've been afraid of getting stoned or getting high that we don't allow for the benefits, right? And we don't allow for the other options in it. And it doesn't have to be that way. Cannabis can be literally whatever you want it to be. And you're in the pilot seat here, and you get to choose. And so if you want to not smoke it, you don't have to smoke it. If you want to not get high, you don't have to get high. If you want to just use it for very specific neck ache and neck pain, and you don't want to use it anywhere else, you can use a topical that you can just rub onto your shoulder. And there is so little lost by using it one time or giving it a try, or even considering it, or not even considering it, but at least not being closed-minded to allow other people to use it. Because I think that's the other step in all this, is saying, I don't care. It may not be for you. That's fine. But maybe it may be beneficial for somebody you know. And maybe that's where, that fear may be limiting.
Mm-hmm.
Thank you.
That's beautiful. And maybe even to add to that, it's something that you said before, is that, maybe you're talking to the Hawaiian shirt guy and you haven't actually got proper advice on proper dosage, the concentration. And so you haven't actually given it the proper chance that it deserves, because again, it just kind of goes back to education, which we want to share with people, because they're going to have a lot more questions on, what are some applications? Because I know on your documentary, you talk about cancer and autism and seizures, and not that these are like the be all and end all treatment that cures everything, but there's a time and place and a role to use these therapies. And so what are some of those tools that people can access to find out more information? Where can they listen to more of your work? And, we can mention the documentary again, Cannabis and Your Doctor, but please share some of these other resources.
Yes, please. Thank you. So the very first step, I would say, I know you guys are based in Canada, but in Canada, we have a wonderful group of physicians as well. And a lot of us have kind of joined hands across the world. And one of the ways we've all joined hands for educational purposes, as well as to provide for our patients, is through the Society of Cannabis Clinicians. And you can go to cannabisclinicians.org, and you can look up a local physician in the Find Your Practitioner site. You can donate. It's a nonprofit organization focused on medical education. You can look up and see if there is research studies done on your particular ailment or diagnosis. And so there's a library that is full of scientific research, all based on different cannabinoids and how they can be helpful in your situation. So that's a great resource for everyone across the globe. Another way you can reach out to me directly, you can email me at Sherry, SHERRY, at MD ReLeaf spelled like a leaf on a tree, RELEAF.com. Or you can go to my website, www.thereliefinstitute.com, or YafaiMD.com. I think that's the last one I got.
We'll add everything to the show notes, so they all get the.
And they can follow
resources.
you on Instagram too, I believe, right?
Oh, yes. I am new to the world of Instagram.
Can't forget the social media.
I'm like a baby in the world of Instagram. I've been on it, I think, for just 3-4 months now. So mid-quarantine,
Awesome.
We started that.
It's a whole other world. Yeah, we have a younger employee now that's teaching us all the ways.
Yeah. You need a young mentor.
You need a young mentor in your life.
Yeah, exactly. I don't think any of us are particularly old, but yes, we all need younger mentors going.
We do.
Yeah.
Yeah. Well, thank you so much. This was a really enlightening conversation, and I know people are going to gain a lot of knowledge from this. So thank you for taking the time to talk to us.
Thank you. Thank you for having me.